Welcome back to Plastic Surgery Decoded, the podcast designed to help you better understand plastic surgery. We take the mystery out of it in plain language. You'll find it interesting and useful whether you are already planning a procedure or you're just curious. I'm your host, Dr. Regina Nouhan, and we are now into Season 5 of the podcast. After you listen to this episode, know that you can explore and enjoy many other topics, either through your favorite podcast app or through the website at plasticsurgerydecoded.com. The first 40 episodes, or Seasons 1, 2, and 3, comprise the Plastic Surgery Decoded Classics, with my singular voice covering cosmetic and reconstructive procedures, skincare, and general questions about plastic surgery. The remainder of episodes, Seasons 4 and 5, are interviews with my colleagues around the country to help you learn about the subject. A great variety to choose from. Remember that this podcast reflects my experience and opinion, as well as those of any guest interviewed. It is not intended to provide medical advice, nor is it a substitute for a formal consultation with your physician. So come along with me as we explore this ever-growing world of plastic surgery. Let's go! Breast implants have been an invaluable tool to enhance or restore breast contour both in the aesthetic setting and for breast reconstruction after cancer. As great as they are, sometimes in the past they've been mired in a bit of controversy. So here's where we bring into the conversation the concept of modern implants. There are new features in place which collectively have reduced inflammation of surrounding tissues, rippling deformity, capsular contracture, and even frequency of rupture or leak. What are these features? And does an implant have to be changed during someone's lifetime? Plus, what's the latest on ALCL, a rare type of lymphoma, and on breast implant illness? We'll find out all of this from Dr. Tracy Pfeifer, a seasoned plastic surgeon who happens to be the current president of the Aesthetic Society. She has a wealth of knowledge, and she's ready to share. So here we go. Well, I'm pleased today to introduce Dr. Tracy Pfeifer. Now, she is a solo private practice plastic surgeon in the New York region, and she did her plastic surgery training at NYU. She also did a fellowship specializing in plastic surgery of the breast with Dr. Hartramp in Atlanta, and that is highly prestigious. Welcome, Dr. Pfeifer.
Thank you so much. It is absolutely a thrill to be here. I love the purpose of your podcast.
Oh, thank you so much. Well, I'd like to start us out. Could you just tell us where you're located and what the scope of your practice is?
Yes, I practice in New York. My main office is in New York City, Manhattan, on 5th Avenue, 94th Street. And then I have a second office out on Long Island in the Hamptons.
Nice.
And I practice aesthetic plastic surgery, specializing in the breast. So I do a lot of breast reductions, augmentations, revision of previous augmentation, breast lifts, and then I do a lot of tummy tucks and brow lifts and eyelid surgery. And then we also love doing injectables, and we're bringing a lot of regenerative practices into the office as well.
Oh, that's a really exciting field. I love hearing that. And how are you enjoying private practice? You get to do everything just the way you want it? Is that the idea?
Yeah, it's interesting because when I first finished my training, I actually joined a rather large group. And I did like the camaraderie of being with other plastic surgeons, but you kind of have something in your own mind about how you want the patient's experience to be.
Yes.
And when you're with a large group, you don't have as much control or any control really sometimes over that patient experience.
Yeah.
So I want to deliver not only exceptional results, but an exceptional patient experience. So you'd have to have a little more control over the situation.
That's great. Well, and it's an extra treat that you're here because you are actually the current president of the Aesthetic Society. I think that's so wonderful, and it's great that our listeners will get to benefit from your knowledge today. So could you tell us a little bit more about the society and what your role entails?
Absolutely. I'm a big history buff, so I'll start with the history. The Aesthetic Society, which is also the American Society for Aesthetic Plastic Surgery, was formed in 1967. And you have to go back several decades because it's hard for people to imagine today what it was like in 1967.
Sure.
But basically, if you wanted to have a facelift or a procedure, it was all backdoor and nobody really admitted that they were doing it, including the patients and the surgeons. So there was a small group of surgeons who were interested in aesthetic plastic surgery, and they would submit papers to be considered for presentation at the national meetings. And the plastic surgery organizations at the time didn't recognize the significance or the value of aesthetic plastic surgery, so they would routinely turn down these submissions. So there was no way for plastic surgeons to educate each other and share the information on the techniques that they were developing and how to produce the best results, etc. So 27 people got together, very famously in Venice.
As one does.
Yeah, as one does, and decided to form this society. So it was 27 people. It was invitation only. You had to be well established in practice and doing aesthetic plastic surgery to be invited to join. And then over time, the organization has grown, decade by decade, and everything is focused on education. And of course, now we have members all the way down through resident, categories. So if you're a plastic surgery resident interested in going into aesthetic plastic surgery, you can, become a member. And then we have, fellowships, and we have active members and retired members. So we have over 2,000 active surgeon members now and over 4,000 members in total.
Yeah, that's incredible.
Yeah, it's really grown a lot. I'm the third woman president, so we just had our first woman president only a couple years ago. And we're focused really on education as our primary focus, how to produce beautiful results with the highest level of patient safety.
Yeah.
And then as things have evolved, culturally and within society, we've also added a component of, practice support, teaching people and mentoring them on the business side of medicine, because it's a fact of life, and we don't really learn much about it when we're residents.
That's really so useful. Well, we're here to update our listeners on the state of breast implants these days, but let's go over some basics first. Could you just tell the listeners, how important have breast implants been to plastic surgeons' ability to achieve good results, both cosmetically and in breast reconstruction after cancer? What are the benefits?
Implants have been a tremendous advance in the field. The first implant was in the 1960s, and it was developed by two surgeons in Dallas. And interestingly, the first person who had breast implants actually wanted to have her ears reduced, which we call otoplasty, and she agreed to have breast implants in exchange for an on-the-house otoplasty. So it's just a little bit of trivia.
Oh my gosh.
She was a little bit of a guinea pig. But the implants have improved over time. We're now on what we would call 6th generation implants. And it's been incredibly important both on the reconstructive side and the aesthetic side. So we want devices that are going to be long-lasting and safe and with a wide range of options so that you can, fit the aesthetic goal of the different individual patients.
Yes.
And we want everything to, feel and look natural. So it's been quite a journey, and the implant manufacturers are really very dedicated to this. They want everyone to have good results that are long-lasting and, above all, have a high safety profile, which they do.
Yeah, absolutely.
If you have a patient who, for example, was a full C before having children, and then she breastfed and she lost some volume, we still have that whole breast tissue envelope, and then we put it in an implant. It's a relatively easy procedure to do. But when you have a patient who's had a mastectomy and all of the breast tissue has been removed, the shape of the implant and the characteristics of the implant are very important in terms of producing a pretty result.
Good point. Again, just some basics. What are the different kinds of implants that are available these days?
Well, when we talk about implants, we talk about the fill. So the fill of the implant can either be saline, which is salt water, or it can be a silicone gel. All of the implants have a shell, which is basically the outer, casing, and all of the shells are made out of silicone. So I think one thing that's confusing for patients is that the silicone as a substance can be anywhere between a liquid all the way up to something very firm like you would use for a chin implant.
Yes.
And then there's all different in-betweens. So We could have a silicone filled implant that is more of the consistency of like molasses,
Mm-hmm.
or we could have something that's more like jello, which we can also use that type of silicone in what we would call a form stable implant. So the implant can either be round, where the width and the height are the same. So if you turn it, it's the same in all dimensions. Or it could be a teardrop shape, where it has a little less fill at the top and then it tapers. So if you look at it, it just looks like the normal shape of the breast.
Like a breast in gravity.
Yeah, exactly. And we call those shaped or teardrop implants. And then there are, I mean, we could get very technical, but there are different fill ratios. So sometimes the implant is filled to like 85% of capacity. So if you put it in the upright position, there's a slight collapse at the top, which can lead to some rippling.
Mm-hmm.
Some of the newer devices are filled more. And then again, there's these different types of gels. So kind of like how dense the gel is, how much does it flow or not flow. And all of these things contribute to what the aesthetic result is going to be for the patient long term.
That's a good overview. Are there some new and improved features regarding implants these days that are worthy of mention?
Well, there's a new implant in the United States that's made by Establishment Labs, and it's called Motiva. And so this type of implant has a different type of surface on the shell. So if you remember, we talked about the shell, sort of like the casing that is the implant surface. That surface can be smooth, where it just feels totally smooth, or it can be what we would call micro-textured, so it's a little rough, or it can be what we now have through the Motiva brand is a nano texture. So there are pros and cons of all the different surface types. So for example, a smooth surface implant, when you put it in the body, the tissue is around it, the breast tissue or whatever tissue is around it will not stick onto the surface of the implant. So that implant moves around in the pocket. And typically it's thought to feel very soft, look very natural. On the downside, it may have a slightly higher capsular contracture rate, which we could talk about later, but we could think of it as scar tissue around the implant.
Yeah.
A microtextured implant, which is available through Mentor, has basically, when the shell is kind of not totally formed yet, they press like a stamp on it. So that gives it this texturing. And that has probably a slightly lower capsular contracture rate and a little more stability. So when we're thinking about stretch over time or somebody's breast who's prone to stretch, and remember these implants have weight, sometimes texture is an advantage because it creates a little bit of friction, so it's harder for the pocket to stretch out, and it can maintain implant position and reduce, sagging over time.
Yes.
They can still have capsular contracture, but they're thought to have lower capsular contracture rates compared to smooth. And then the new thing is Motiva. So Motiva is a nanotexture device, so it's 0.4 microns, I believe. And it forms very little capsules, so it has the lowest inflammatory response to the presence of the device. The immune system creates inflammation in response to the presence of an implant, which can then go on to create capsular contracture or this scar tissue. So the fact that the Motiva device has the lowest inflammation is good because it could lower the capsular contracture rate, which is somewhere between 2 and 7%. A potential downside, which I've just started using them, so I can't say 100%, they've used them in Europe for a long period of time,
Gotcha.
is that capsule is going to be thin and maybe they're going to be a little more prone to having some stretch. But there are things that we can do to mitigate that.
Yeah.
They also have a very unique way of making them where the gel and the shell are kind of like one. So there's very little rippling. So every implant has its pros and cons, and that's why it's great to have choices.
Absolutely.
Because you can customize it for each patient depending on what their priorities are and what they might be or not be prone to in terms of how they're going to heal and their long-term results over many years.
That is wonderful. It is so great for there to be so many choices now available so that the surgeon and the patient can decide together what's going to be best.
Absolutely. And I do want to mention that there are also saline filled devices through Allergan. Allergan has an extensive portfolio of breast
Yes.
implants, both saline filled and silicone filled. They have a lot of different sizes and different cohesiveness of the gels. And then there's another implant called the Ideal implant, which I haven't used, but that's another saline filled device that's available to people that reportedly has less rippling compared to some other saline filled devices.
You know, we've mentioned the word rippling. Could you explain what that means in terms of a breast implant or the appearance of a breast externally and what causes that or what can be done to avoid it? What are your thoughts about rippling?
So, rippling can happen just due to the nature of the implant. So, if you imagine you have an implant and it has a volume, and the volume is filled 85%, then if you put that implant upright, you're going to see a little bit of waviness in the surface of the shell because it's not 100% full and, sort of tense, filling it out and preventing the rippling.
So gravity's pulling most of that substance down.
Yeah, you're in the upright position and gravity's pulling it down, and you're going to maybe see some rippling in the cleavage area. Sometimes you'll see it on the side. So, rippling is part of an implant naturally. It can be reduced by the type of gel that's in the implant and the degree to which the shell is filled. So if it's filled 95% with a very cohesive, like jello type silicone, it's going to ripple theoretically less. Whether or not the patient is aware of the rippling depends a lot on several things, one of which is her tissue thickness.
Mm-hmm.
So if you have thicker tissue, it's kind of like the princess and the pea in reverse. If you have thick tissue overlying your implant, you're not going to see the characteristics of the implant. You're not going to see the rippling.
Right.
A lot of people, when they're standing upright, they're not aware of it. But if they bend over and then gravity is pulling on the weight and the capsule is pulling on the overlying tissue, then sometimes you see what we call traction rippling. Or you could be standing up and you look fine in the cleavage area, but if you run your fingers on the side of the breast, you feel a little rippling. So it's not visible, but you feel it. And that's because a lot of us who need breast implants, our tissues are really thin on the outside of our breast, like where the arm meets the chest. So you have very thin coverage there, so you might feel it. Now, the other thing that can produce rippling is capsular contracture.
Mm-hmm.
So the implant has a natural width, it has a diameter. And if the capsule is tightening and kind of squeezing it a little bit, it can create rippling.
And again, capsule is kind of like a rind of the body's own scar tissue that is tightening up around the implant. It's not the implant getting tight.
It's not the implant, it's not, right. So when you have an implant placed, your immune system looks at it, whether it's a breast implant or a joint replacement, and it says, hey, this isn't part of our body because there's no cell surface markers on it. And it says, well, we don't know what this is. It could be a pacemaker, it could be anything. And it makes a little veil of tissue around it, which we call a capsule.
Mm-hmm.
Now that capsule can be thin and very gauzy and like imperceptible, or it can become thicker and thicker and thicker. Like it could be more like rubbery because it's so thick, or it could be like an eggshell because it's been in there for a long time. And when these normally thin capsules get a little bit thicker, it can actually squeeze and compress the implant. So instead of, let's say an implant diameter is 12 centimeters, well, it starts squeezing it down into its smallest diameter. So maybe now it's like 10 and a half. And that can cause rippling as well, in addition to feeling tight and displacing the implant. Capsular contracture can create rippling.
Yeah.
So we want to obviously avoid all of these things because we don't want to have rippling.
Yes.
And we don't want capsular contracture either.
Oh, exactly right. And then let's talk about implant rupture. And I understand that you would refer to that phenomenon with a better moniker, but could you tell us what it is and what the potential sequelae are?
Sure, absolutely. So the two things we always want to talk to patients about are capsular contracture and then implant rupture. And my own personal take on the language is that it's language that was developed decades ago when the implants had very thin shells and they would tear, and the silicone inside was liquid like, so it would seep out. So the word that is used in all the official documents with the FDA, the way the radiologists report out things when they're doing mammograms and ultrasounds and MRIs, the two words that they use are rupture and leak. And I don't prefer either of those words because I think they're scary sounding words that do not accurately describe modern implants. So when we say rupture, if I was a patient, I would say there's like an explosion in my body.
Yeah, terrible thought.
And if somebody said leak to me, I would think there's stuff seeping all over my body going everywhere.
Oh gosh, very scary.
Yeah. So what actually happens is that if you imagine the shell of the implant folding a little bit, maybe the pocket is a little tight and the implant is folded. And just like a piece of paper, you fold it back and forth, back and forth, back and forth, and eventually that paper will thin out and split. And that's what can happen to a modern implant, which they call a rupture.
Yeah, that's a great analogy.
Yeah. But when you get that tear, it's really a tear in the shell, and then the silicone that's inside is more like a jello honey consistency. So it doesn't really leak out. It just kind of sits there. Now, if I took the implant and I squeezed it from the pressure, it would kind of pooch out, and then when I release the pressure, it would go back in. So that's for modern implants. Now, older implants, you can have more disruption where the shell really is kind of starburst open and the silicone could be outside the shell and sometimes the capsule. The important point for patients to know is that it is not dangerous for you to have a quote unquote rupture. The material inside the implant is silicone, the shell itself is silicone, so your body is constantly being exposed to silicone, just like it is with a lot of other medical devices.
True.
So for a patient, it really comes down to a personal decision. If a person has older generation implants, let's say they had them from the 80s, if they have a quote-unquote rupture, those we will almost always take out because they have the older generation of silicone. They usually have capsular contracture in response to the rupture, so those are going to come out. New generation devices, if the ultrasound shows that you might have a rupture, and then sometimes we'll get an MRI to confirm it. If the patient looks good, she's not concerned about having a tear, there's no medical reason why you have to remove it. And remember, all surgery has some potential downside risk. So
True.
It's not like, oh, you're just going to take it out, put another one, but everything's going to be perfect. I mean, it usually is, but sometimes something is not 100%
Can't guarantee
the way.
that, yeah.
Right. So it's up to the patient. If the patient feels like, oh, I'm not comfortable knowing that this implant is not intact, I'm going to take it out. And that's how we do it in my practice.
Well, should patients expect to have their implants exchanged during their lifetime anyway?
Yeah, so I love this because it's kind of like an old wives' tale in a way. So back in the day, meaning like in the 70s and the 80s, the shells were thinner, the silicone was more liquid-like, and the shells would develop tears, and it was thought it would happen around the 10-year mark. And silicone, if it's in that more liquid-like form, which it was, would seep out, and then if the surgeon went in to remove this implant, the silicone is very sticky and it gets on everything. And so you want to make sure, as the surgeon taking care of the patient, that you take out all of that silicone, you don't leave any inside. Not because it's going to cause a medical problem, but because the body will make like little individual shells, capsules all around this silicone, and you could feel a lump in your breast, and then you go to the radiologist, you get an ultrasound, they tell you, oh, it's just silicone, don't worry about it. But no woman wants to feel a lump in her breast.
Right.
So for the surgeon, it would be a lot easier technically just to take out an implant before it has a tear in it or a rupture, and then replace it with a new one that could last another 10 years.
Sure.
And that was great for back then. But now we have modern implants, which really are warranted for life by the manufacturer. So, assuming that things are okay, the manufacturer expects the implant to last a lifetime.
Mm-hmm.
That is not always the case because even with the modern implants, you could have a tear in the shell. So, with a modern day implant, I think it's up to the patient and the physician to decide when and if they want to change the implant. From my viewpoint, there is no reason to take out an implant every 10 years. There is no data to support that with a modern implant.
Gotcha.
And I tell my patients it's usually for a cosmetic reason that you're going to want to have a revision. You can count on having a revision, whether you're 23 or 45. Maybe you have it at a young age. You have 2 children and you breastfeed and you need to change the implant to a slightly fuller size.
Yeah.
Maybe you are 62 now and you gained 15 pounds and you feel like your breasts are too big. All of these things are possibilities, but they're all cosmetic reasons for having a revision. It's also important to know that the manufacturers are very confident in their product, and so they have warranties with lifetime replacement of the implant if it does quote unquote rupture. So at any point, if your implant ruptures, they will give you a new one at no cost.
It's a pretty sweet deal.
Yeah, it's not bad.
Yeah. Again, as you're referring to modern implants, what is it that is different about the modern current implant compared to implants available maybe 30 years ago?
Yeah, the modern implants are totally different. So the shells were redesigned to be more durable and more like a solid so that the silicone couldn't seep across the shell.
Or bleed through.
Bleed through, that's the correct word. And the silicone in the implant was also changed. So silicone is basically strands that is like cross-linked. So the longer the strands and the more cross-linking, the more like jello the silicone can be. So they modify that, and all the current implants have slightly different types of gel in terms of how long the strands are and how much cross-linking there is.
Mm-hmm.
But all of the changes resulted in shells that were less likely to tear and gel that was less likely to, seep out and act like water and really like get into your breast tissue if there was a tear in the shell.
Right.
So today, if I took a modern silicone implant and like cut it in half, the silicone wouldn't even like really come out of it. I'd have to like squeeze it and it would kind of pooch out and then it would like come back in when I release the pressure. So they're really, really great. And it's also a cosmetic benefit because if you choose a certain device, you can maintain fullness in the top half of the implant. Whereas in the past, it would all kind of, gravity would all pull it down to the lower part of the implant.
Excellent point. Once implants are surgically placed and the patient is happy, everything turned out great, does the patient need regular implant checks?
I mean, I'm an advocate of yearly follow-up. I think it's important because sometimes the patient might have a little something going on, like maybe they have early stage capsular contracture. And then they'll feel awkward calling the office because they're not sure if it's really a problem or not. They feel like maybe they're imposing. They don't want to waste people's time, which is totally not how the office or myself sees it.
Yeah.
But I think it's just better to have a scheduled yearly follow-up visit. We don't charge patients for that.
So nice.
If they have any questions, they can ask you. You can reassure them that things are okay. Or if you need to get an ultrasound or whatever, we can reinforce, are you getting your mammograms or not? And also, we like our patients to take antibiotics before dental procedures to help prevent capsular contracture.
Excellent.
And so it's a good way for us to remind them, or you make sure you're taking your antibiotic before your dental visits, even for a regular cleaning.
Really good info.
And then some doctors are incorporating ultrasound into their practices. So the patient comes in, they have their own little ultrasound device, and they can check for any fluid that could be around the implant, or if they do have a rupture. So,
do you feel like ultrasound is a good test for someone to have just for surveillance of the implant? Or how often do you feel like they might need something like an MRI?
We ask our patients to get an ultrasound once a year. I don't offer it in the office currently, but we are going to start that.
Great.
MRI is a little, the FDA recommended MRI, I think it was starting 3 years after the initial surgery, then every 2 years. But the thing was, there wasn't really a proven health benefit to do that, and the insurance companies really weren't covering it.
Yes.
So, unless there's something abnormal on the mammogram or the ultrasound, we don't routinely send the patients for MRI. That being said, if a patient wants to have an MRI, we will write the prescription for it so that they feel confident that everything is okay.
Yeah, makes sense. Now, there's a type of malignancy that's been associated with breast implants called anaplastic large cell lymphoma, or ALCL. Could you tell us about that briefly?
My first patient that I ever saw with it was in 2014, and she had what we call macrotexture devices. And she had this fluid buildup around the implant, so the breast would be swollen and enlarged, and you could tap off this fluid. This had been going on for 3 years, where she would have the fluid tapped off and then it would recur. And then she came to my office and I said, I've heard of this really rare thing called ALCL. Let's tap the fluid and see if it's positive. And it was.
Mm.
So when a patient hears that they have a lymphoma, it's very scary, but this type of lymphoma, I don't want to say it's not a lymphoma, but it behaves different from a lymphoma without a breast implant. So if you have no breast implant and you develop this type of breast lymphoma, ALCL, it's very aggressive and you need chemotherapy for treatment. What we notice with the patients who have it associated with breast implants is that in most cases, it's not that aggressive. And in fact, the treatment is to take out the implant and take out the capsule. And very, very rarely does the patient need chemotherapy because it hasn't really spread to involve the capsule or throughout the body.
Yes, yes.
So the way I think about it is most of these cases are like a pre-lymphoma because if it was truly lymphoma, you'd need chemotherapy. Now, why is this happening? The FDA started following the cases probably in 2011, maybe 2008. And as plastic surgeons became more and more aware of this possibility, they started sending the fluid out to be examined, so more cases were identified. So there were a couple hundred, and there's 600. Now I believe there's about 1,600 cases in the FDA database that have been reported worldwide. And it's estimated that there's about 30 million texture devices worldwide. That number could be wrong, and we don't know all of the different types of textures that are being used.
Sure.
But from what we know from the database, about 87% of the cases are from the macro texture type of implant. So I don't recall the year, but it was before COVID, the FDA issued a device recall, which meant that every surgeon in the U.S. was told, if you have these implants in your inventory, please send them back and do not use them. And the patients were sent a notification to contact their physician and to be on the lookout for any symptoms that may be associated with it, which is different from a patient recall where the patient would have been sent a letter saying, hey, you have a medical device which could be causing you a problem. You need to come in because we're going to recommend that the device needs to be removed. So that was not what happened, because if you statistically look at it, and I know statistics are not necessarily reassuring to everybody, but if you look at it from a purely statistical standpoint, your risk of dying from a macrotexture device is like less than living in New York City for like 2 days. So,
Okay. Pretty good odds then.
And to this day, the recommendation is not that you take them out, because there is a risk associated with surgery from,
Yeah.
anesthesia complications.
So just be vigilant.
Be vigilant, or if you're really worried about it, we're going to take it out because you don't have a good quality of life because you're worried about your implant.
Yeah.
So it's on a case-by-case basis. Now, obviously, if the patient develops some signs or symptoms, like swelling, or we see some fluid on an ultrasound, or they have an abnormal MRI, then we're going to, pursue it further. And we've actually had a few cases now of squamous cell carcinoma, although it's very, very rare. It's extremely rare. But that's why I think patients should have follow-up on an annual basis.
Yeah, that makes perfect sense. And that gives the surgeon and the patient peace of mind, I think.
Yeah.
Well, what is breast implant illness, or BII? Is that something you can test or screen for? Is there a significance to the fact that it doesn't really have a consistent presentation from patient to patient? Tell us your thoughts about that.
Yeah, breast implant illness has been something that we've been studying now for years. And in fact, the Aesthetic Society, through our research foundation, funded a several $100,000 study looking at women who had self-reported symptoms of breast implant illness. The challenge for us as physicians is to try to figure out, is it associated with the implants or not, and who might be more prone to it? Are there any tests that we can screen patients with? So what has happened in the past is that a patient would have symptoms that could be associated with many things: muscle pain, fatigue, poor concentration, foggy thinking and memory. And when you would run the usual labs to rule out, for example, some type of inflammatory disorder, everything's like normal, but yet the patient doesn't feel well. And for a long time, to our chagrin, I would say, we thought that the patients really were not necessarily having these symptoms. And so some plastic surgeons would kind of poo-poo it and ignore the patients.
Dismissive, yeah.
Yeah. So we did a large study. Dr. Glicksman and Dr. McGuire spent years, and other researchers were involved.
We had Dr. McGuire on this podcast a couple years ago, yeah.
Oh yeah, well she probably explained the whole thing. But the bottom line was, we were looking for additional lab tests that we don't usually check to see if any of them were associated with symptoms.
Mm-hmm.
And then very importantly, whether or not removal of the capsule led to an improvement of symptoms, and we'll come back to that in a second, and whether or not patients felt better with the implant coming out.
Mm-hmm.
So their research showed that of all the ones they tested, there were no labs that were helpful in identifying patients. There was no association with taking out the total capsule or not in terms of relieving symptoms, and that some patients had relief of symptoms when the implant was removed.
Mm-hmm.
So this was very important for two main reasons. One is that there were some plastic surgeons who believed that taking out the total capsule was necessary for relief of symptoms. And in a patient who has very little breast tissue, if you try to take out the total capsule, number one, you can create a deformity of the remaining breast tissue where you get like a rippling and indentations.
Mm-hmm.
And number two, if the capsule is laying on the ribs, if it's in the subpectoral pocket and you're trying to shave the capsule off the ribs because it's stuck to the ribs, it could be an operation that has complications. And it would require a lot of times to make a really big incision to have access to get the whole capsule out. And so many patients felt that the whole capsule had to be removed. They would ask the surgeon to video the surgery, to take pictures of the capsule to prove that it had been done. So this was a very important study showing that total removal of the capsule was not necessary for relief of symptoms. The other interesting thing that is possibly emerging is that there may be a component of how the patient feels about the implant that's contributing to the symptoms. And I want to make sure that I'm not saying something that's misinterpreted. I'm not saying that the patients don't experience these symptoms or that they're crazy or anything like that.
No.
But there does seem to be a component of how the patient's brain is thinking about the implant.
Interesting.
It's kind of like going back to where we were, where we thought, oh, it's more dependent on the patient than the actual device. But there are some things that are coming out in some of the research. It's kind of like what your overall personality is may be somehow impacting it.
Mm-hmm.
But the bottom line is that if a patient doesn't feel well with their breast implants and you work them up for other possible medical conditions that could cause their symptoms, a lot of patients want to have their implants out because they feel like, I've tried everything, there's no diagnosis, maybe it's the implants. And so we take them out, we tell them, your symptoms may improve or they may not improve.
Mm-hmm.
And, as I've been thinking about this over the years, I'm like, what is going on with this? I think about people who have, irritable bowel. They have all these problems in the U.S., but when they go overseas and eat in Italy and France, whatever they want,
Right.
they feel fine. They come back here, they feel draggy and sluggish because we have different ingredients and chemicals in our foods.
Yeah.
And, I just wonder if different people's immune systems, react differently to devices.
Sure.
And that it's going to be hard to figure it out because it's probably a small subset of people. And so it's going to be hard to figure out who are the people that are more at risk of having symptoms when they have a device.
Yeah.
And I also think that a lot of people, when they go through menopause, they have changes. That's one thing.
Sure.
And maybe it's happening in older people too, who are having, like hip replacements, but when they don't feel great, everybody's like, well, you're 68, so of course you don't feel great,
Right.
or something like that.
It's very insightful.
So I think there's a lot more to learn, but the most important thing for patients is that your plastic surgeon should be open to discussing all of these things and not being dismissive, as you said, of your symptoms. And
Truth.
we're there to help patients in all situations.
Yeah, that's great information. Well, Dr. Tracy Pfeifer, you have just been a wealth of knowledge for us, sharing with the listeners. Appreciate that so much. I'm wondering if you anticipate or even just wish for any future changes in implants or implant surgery, anything that you see on the horizon or that you'd like to see to further the concept and what we can offer patients.
Well, there's two big things right now. One is that patients who have been on Dr. Google will know you could have your implant either on top of the muscle or under the muscle, but there's also something called the subfascial pocket. And recent anatomic studies have further defined this subfascial pocket. And I think it's a very interesting position for the implant to be in because it has a lot of benefits. So I think the subfascial pocket is going to potentially gain in popularity.
Mm-hmm.
There are attachments on the inside and the outside of the breast that attach to the chest wall. And so it can really stabilize the position of the implant, which is important for us over time. We don't want it sliding out to the side or sagging. So I think that's really exciting that the anatomy is being defined in this detail. And then the one thing that I would love to see is, because the texture devices have this low chance, but still present, of ALCL, most surgeons in the U.S. have abandoned the use of teardrop-shaped implants because they have to be textured to keep them in the right orientation.
Mm-hmm. That anatomic shape.
The anatomic shape.
Because if it's not catching the tissues with the texture, it might spin around and look funny.
Yep. You don't want an upside-down teardrop-shaped implant.
Right.
And when these shaped implants were first introduced, they were so popular with the reconstructive surgeons who were using them in patients who had had mastectomies because it mimics the natural shape of the breast. So they a lot of them switched to using the shaped.
Yeah.
And now they don't have that option because, of course, you're not going to put even a remote possibility of a textured implant that might have ALCL. You're not going to put that in a breast cancer survivor patient.
Right.
So I would love to see teardrop-shaped implants with a smooth surface, which we know is not associated with ALCL, as far as our research shows.
Mm-hmm.
And maybe it has tabs on it so that you could sew it in and keep it in position, because they do have that for tissue expanders.
Right.
So I would love to see that for the reconstructive surgeons. Teardrop shape, smooth, with tabs, so that we can get that natural, really natural look.
Very customized but wonderful implant. That would be great.
And that would be a third thing. That
Yes.
you could 3D scan our patients and
Oh,
get
yes.
custom implants for each one.
Surely that's coming.
Yeah. Oh, it's coming. It's going to happen. It'll happen.
Oh, that'll be a great day. Oh my
Yeah.
gosh. Well, any final thoughts you'd like to share with the listeners, either about breast implants or just about breast plastic surgery in general?
I would just say look for a surgeon who's board certified by the American Board of Plastic Surgery. I always think it's good if you're in an area that has a lot of plastic surgeons to look for somebody who specializes in the area or the procedure that you want.
Yes, that's nice.
If you're in a more remote area, you don't have as much access to different people. But if you're in a dense populated area, there are people in your area who specialize in aesthetic surgery of the breast or rhinoplasty, whatever you're looking for.
Mm-hmm.
And then just be aware and smart when you're in somebody's office that if they're not answering your questions, I call that kind of like a red flag alert. Trust your instinct. If you get a good vibe that they're going to take good care of you, they have your best interests at heart, I think you'll be in good hands. But if you don't get that feeling, keep looking around until you find the right person.
Oh gosh. Well, those are some wise words. Thank you so much. All right, Dr. Tracy Pfeifer, thank you so much for being with us today.
It was my pleasure. Thank you for inviting me, and thank you for all that you're doing to educate patients.
Oh, thank you.